Lexi, thank you so much for having me. And many thanks to Brad, of course, in Britain, and for Rupa Health and Boston Heart for making this presentation a reality. So I would like to actually, first of all, welcome everyone who took the time during the day to listen to this webinar. It is packed with a lot of information. If you have questions, please drop them into the chat box because we're going to have about 15 minutes toward the end to be able to go over some of your questions. And remember that we only have 1 hour today, so it's by no means going to be a super exhaustive presentation, but I think it's going to give you practical tips and highlights and things that you can start doing in your practice that will potentially expand your opportunity to really provide state of the art services to cardiovascular patients. In terms of what we're doing today is that we putting precision cardiology into daily practice, equipping practitioners to apply advanced testing and to tailor this testing to the needs of their patient. If you've been following me for a little bit, and if you're not, you potentially could get access to several webinars that have taken place in the late 2023 through Boston Heart's Diagnostics. In those webinars, we have positioned the testing to look at heterogenic lipid phenotypes, inflammatory pathways, and discuss how monogenic and polygenic risk score assessment may benefit your patients in terms of the knowing more precisely their risk of cardiovascular adverse events and picking out lifestyle strategies as well as pharmaceutical strategies for their specific issues. So I encourage you to explore these webinars on the Boston Heart Diagnostic website, as well as one of my previous webinars for Rupa Health. You will find in those webinars a stepwise approach to lipids, metabolics, metabolomics, inflammation, endothelial function, and of course, genetics. And the reason that we're doing this is very straightforward. We do know from previously executed studies in the primary, secondary prevention, and even those in high risk patients, that the traditional cardiovascular care model of giving statin medications to reduce the risk of major adverse cardiovascular events only yields about a 30% or so risk reduction. We do know that additional factors that have to do with inflammatory, metabolic, metabolomic, and genetic predispositions, as well as environmental influences, actually drive the majority of remaining risk for cardiovascular events. And while in the literature it's called residual risk, it actually accounts for up to 75% of the risk that potentially could be reduced for your patients. If you go through the webinars that have previously been given in 2023, including the university webinar, you will find a discussion of heterogenic lipid phenotype. And the main points are summarized here, and here's the relevant publication for you in case you decide to explore it on your own. Heterogenic lipid phenotype really puts ApoB as the major predictor of cardiovascular events, above and beyond LDL cholesterol. It looks at so-called dyslipidemic triad, which is a combination of ApoB, triglycerides, high-density lipoprotein, and small-dense LDL cholesterol. And it uses ApoB and triglyceride patterns to assign a specific phenotype that you can use to decide on the lifestyle and pharmaceutical interventions for your patients. This is actually very simple conceptually. During the insulin resistance, tissue level insulin resistance, such as liver or systemic insulin resistance, that pushes the liver actually to increase ApoB production and increase triglyceride production. The ApoB, a triglyceride rich particles, as undergo continuous exchange with other lipoproteins that have cholesterol esters, because the triglyceride rich particles are more susceptible to lipoprotein lipases, they get degraded in the circulation fairly quickly. And so you end up with a situation of high ApoB, high triglycerides, small dense LDL cholesterol, and actual low HDL, as HDL gets stripped of its protective coating and gets excreted by the kidney. I don't want to belabor this point because this is something that you can absolutely find in your webinars or read the paper itself. And using that information, we typically progress to derive something called heterogenic lipid phenotype. And the reason why this is important is that patients very often wonder, and practitioners are trying to help the patients to embark on the lifestyle regimen that is most conducive to reversal of the abnormalities that are impacting their cardiovascular risk. And understanding what allergenic lipid phenotype a patient may represent is important, as well as understanding the shifts in allergenic lipid phenotypes that could occur with your interventions. You probably are also familiar with the inflammation being the major root cause of atherosclerosis. Inflammation and immune system activation, as well as vascular immune response, are the foundational biological abnormalities or steps and processes that occur with atherosclerosis. And of course, you know that there are multiple markers that we could potentially determine to decide on what kind of inflammatory path our patients are following. And of course, that supplements our opportunity to understand our patients. And finally, not to be missed and probably even emphasized in the future, genetics. We are very much used to monogenic diseases, familial hypercholesterolemia being a quintessential monogenic disease where single nucleotide polymorphisms differences in the genetic profile sometimes predispose our patients to very excessive LDL or triglyceride reduction, and of course, increase their cardiovascular risk. But we are heading very rapidly to widespread implementation of polygenic risk scores. And a lot of this work, of course, has been the foundational work that stemmed from genome-wide association studies, but has been became possible because of the advances actually in machine learning and artificial intelligence, where we could look not just at the disease-associated single nucleotide polymorphisms, but at the clusters of those single nucleotide polymorphisms in individuals who do not necessarily clinically have a disease yet, to forecast their risk versus the reference population. Again, there is a webinar on this that was given in late 2023, which goes into a little bit more detail. So using this information at the Holistic Heart Centers, we build a precision cardiology pathway. And this pathway is the cornerstone of our Fit New Genes program, which is the personalized precision risk program for each of the patients who come to seek this level of medical care. We use something called Heartwell toolkit, which is a trademark collection of biomarkers, genetic and epigenetic tests to allow us to provide a personalized action plan for heart and vascular health for our patients. And the building blocks of that toolkit are actually things that I call patients and panels. And we are using very much or a lot of Boston Heart panels as well as other provider panels to really guide our patients in the most precise application of these concepts. And so I thought the best way to illustrate this is to go through case presentations, give you a flavor of how you would apply these advanced concepts of heterogenic lipid phenotypes and inflammation and mono and polygenic risk scores in the precision cardiology pathway. So our first case is a patient who is seeking health optimization. And this is copied and pasted from her intake form. She is a 36-year-old woman. She was found to have elevated cholesterol, mild elevation based on her recent physical exam. And her goal is to understand how to improve her heart pulse, ideally without the use of medication. As happens very commonly, she was told by her treating physician to implement lifestyle changes, diet and exercise. And unfortunately, she's at a loss because she happens to be a very health conscious individual. And she already has been practicing a lot of healthy lifestyle, healthy steps. She's limiting animal protein. She eats fish and chicken predominantly, but she primarily eats a plant-based diet. You could see here she doesn't eat any red meat, lots of salad and vegetables, exercise 2 times per week, very diverse. And actually, she also is a meditation practitioner for herself. So it's very challenging for a patient like this who already had invested a lot of effort and time into practicing what they would consider a very hard, healthy anti-aging approach at the age of 36, be told that they have elevated cholesterol and they have to do diet and exercise. For logical question, of course, is what diet, what exercise? And our focus for this patient took advantage of the Boston Heart Diagnostic dry blood spot testing. This patient was in a 6 month program where we used dry blood spot testing for baseline blood biomarkers. We also used Boston Heart Lab polygenic risk scores and GI balance kit for her genome and microbiome workup, as well as a pathway specific genomics from a company that is a recent partner in Boston Heart Diagnostic Universe, GB Insight. And we repeated her biomarkers at 6 months, and that was our dry blood spot kit usage number 2. In the Rupa dashboard, you can actually dial in dry blood spot from Boston Heart Diagnostics. You could see that there are quite a few panels. And if you've been a Rupa user, you can compare those panels for your specific needs because they do have a comparison tool. I have a custom made dry blood spot panel, which basically allows me to expand the testing a little bit, but you'll probably find that one of those panels or a couple will be well aligned with what you're trying to accomplish in your practice. And so for this patient, on a dry blood spot testing, you could see that her total cholesterol is mildly elevated. So is her direct LDL cholesterol. Her HDL cholesterol is surprisingly lower than you would expect from a 36-year-old woman who is otherwise in excellent physical shape and is very health conscious. Her triglycerides, while they're in the green zone, should really be in double digits. These are fasting triglycerides, so she's 124. And you see that sprinkle of yellow in the intermediate cholesterol metabolites, including ApoB, including small dense LDL-C. So that's already hinting that this lipidemic triad may be taking place. And you could see that based on her lipid ratios, as well as 2 red flags, and they're literally red. Lipoprotein little a is elevated at 79, and of course, C-reactive protein at 4.0. Now, this is a healthy patient without any intervening illnesses. So this is an opportunity for us to remarkably improve this patient's overall health trajectory. The issue with such young patients who are 36 is that they don't fall within the age bounds of our population-based risk estimates. If you have used, for example, atherosclerotic cardiovascular disease population-based risk estimate, you will find that a 36-year-old is not eligible because those risk estimates start at about 40 years of age or so. You certainly can use a MESA calculator here to prognosticate her 10-year risk of adverse cardiovascular events, which even with this panel will be low, but her lifetime risk, of course, is high. And she happens to have a family history. Her grandmother passed away fairly young from aortic valve issue, although she's not sure which one. And of course, this is very worrisome now that you see this lipoprotein little a elevation. In a more general health domain, her vitamin D is in the, technically it's considered a normal range, but integrative practitioners know that 43 is probably not optimal, and her homocysteine is at top 10. So what we did with that patient is that we actually looked at her genetics, and this is part of the polygenic and monogenic assessment. This assessment is from the affiliated Boston Heart partner, where you could see that she actually didn't have any classical familial hypercholesterolemia variants, but she had some variants of what's called variants of uncertain significance that have increased her risk. And one of the strongest ones here, of course, is ApoE. So this is ApoE4 heterozygous patient. In addition, she has polygenic scores in the lipoprotein A pathway that identify her as high risk. So it's important for this patient, even though she already is doing a lot of diet and exercise, to actually be on aspirin therapy because literature supports doing it for patients who are at high risk based on their polygenic risk scores, even when their serum levels may not necessarily be way too high. And sometimes their serum levels are actually normal. I also did microbiome GI balance. This was just to show you what is available in that microbiome report. Hers was entirely normal as would be expected because this is a patient who already committed quite a bit to very focused and consistent lifestyle intervention. After following our program, you could see here we ran dry blood spot number 2. So still works to be done and her cholesterol, her ApoB, but we're seeing very nice reversal of this lipidemic triad. Her small dense LDL-C has now dropped into the normal range. All her ratios normalized and her inflammation had a fourfold decrease. She is with C-reactive protein of 1.1. Obviously, the more optimal one will be less than 1. She's very close. She had a very mild decrease in lipoprotein little a, but I don't take lipoprotein little a reductions at face value because this happens to be a marker that fluctuates quite significantly, even with lifestyle or pharmacological needs. And you could see, of course, that while her vitamin D is hanging around at 40, her homocysteine had significant improvement. In summary, the dry blood spot combination, genetic workup, and GI kit were instrumental in pointing this patient who's already invested a lot of time and money into her lifestyle strategy toward the path that could potentially improve her situation. And the ApoB of 118, while it's not optimal, is a much more acceptable situation for her now that there is significantly less inflammation and the metabolic impact has been removed. You could see also a drop in her triglycerides, which is fairly precipitous. So potentially what we're seeing right now with these cholesterol elevations is in a way expression of her underlying genetic predispositions. And we can pivot toward addressing these through additional supplementation and potentially pharmacological needs. Her coronary artery calcium score is 0, so she definitely has an opportunity to work on this cholesterol panel now that her dyslipidemic triad is addressed and her inflammation has reduced and potentially avoid various medications. So our second case here is actually a patient with very complex issues. This patient is 49. This patient had a hysterectomy a few years prior due to endometriosis. And at same point, she was also trying to improve her body composition, although she was never overweight, but she was essentially committing to a healthier diet. And in her mind, that healthier diet was more fats, less carbs. So she excluded a lot of carbs. And so when she presented to us, and you could see this dark red bars, her March reading, then September reading, then her February 24 reading, she presented with a total cholesterol of 361. Her all the direct LDL-C was 252. ApoB is 157, oxyl is 86 and she has evidence of vascular inflammation. So PPL-2 activity is 159. So I want to make sure that I see some of the questions come up is that this is a presentation about laboratory testing. This is not a presentation about exact protocols that we use at the holistic heart centers. Our protocols are obviously proprietary, but I will share some resources toward the end that will help you get additional information and actually learn what protocols we are using. So in this lady, you could see that a significant improvement in her laboratories as we worked with her with non-pharmacological therapies. So she's in our proprietary Fit New Genes program. And so all the interventions that we do in that program are focused on cardiometabolic and lifestyle modification using combinations of nutritional approaches and supplementation as well as some pharmacological interventions, but they're not necessarily statin-based interventions. Obviously, to modify her risk, we do need to drop even her February parameters to a more acceptable range, and she's getting close. We do need some of the reduction that is likely to protect her vascular system for a long time because she's only 49 years of age. And the biggest impact here that actually influenced this change was not only cardiometabolic modification through nutrition and supplements, but actual institution of bioidentical hormonal replacement therapy. So the question then is, what else can we do? Because this patient, again, this is her genetic profile. And you could see that she does not have the classic variants of familial hypercholesterolemia. Given her initial levels of cholesterol, she was told specifically to be on statin medications and was labeled as familial hypercholesterolemia patient. This is certainly not classic familial hypercholesterolemia, This is more of a polygenic pattern. And actually, this pattern is combined hyperlipidemia, one of the six pathways that we typically look at in terms of polygenic determinants of what may be guiding patients' lipid profile. This is also another case of ApoE4 heterozygous individual. And because these slides do not allow me to pull all of the reports in, I can also tell you that she has endothelial dysfunction genetics, so 9p21. So the fact that we're finding this LPPLA2 activity elevation, which tells us about possibly vascular inflammation, is significant, even though her coronary artery calcium score is a 0. At 49 years of age, even with these parameters, her vascular risk will put her somewhere in the intermediate or low to intermediate arena for statin therapy, but her lifetime risk continues to be high unless we modify a lot of these parameters. And so you may ask yourself, okay, I know that she needs to drop her ApoB and LDL cholesterol and LPPLA2 activity to more acceptable levels, and she's already going there. But what is the impact of this genetics and all the other things that have transpired with that patient? The fact that she was essentially in early menopause, what is the impact? Where that residual risk, where can I find it? And this should be familiar to many people. This is a well-known test, a mobility test, and you could see that she is somebody who has high amount of LDL particles, primarily small. And as she's going through the program itself, she's demonstrating a reduction in some of these parameters. But where would be the next opportunity for intervention? And we know from the studies that were done in 2015, 2018 or so, in conjunction with the Jupiter study, that there is rhyme and reason to actually check not just LDL particles, but additional particles such as small LDL particles and large VLDL particles. And the reason to do this is that we know that residual particles, small LDL particles, and large VLDLPs are associated with additional risk, so-called residual risk, part of that 70% residual risk equation. And we know that we can modify it with and without statin therapy. And we also know what the pattern might be for those patients who are not responding to statins. We also know, for example, that HDL particles and large HDL particles are inversely associated with cardiovascular risk. Again, Jupiter study, some of the earlier studies, and this is actually NMR, which is a much easier test than ion mobility and holds a great opportunity for comprehensive analysis because it gives us very robust associations for HDL particles and large HDLPs. And so we can use this information to really pinpoint or target the areas of intervention for this particular patient. And so this was a patient where I did a modified lipomap analysis. I have something called atherogenic lipid phenotype that combines some of the tests that are proprietary to Boston Heart Diagnostics. So your HDL map, your cholesterol balance test, as well as lipomap, which is essentially an NMR advanced lipid analytics. And you could see from this patient results that her HDL map is actually quite favorable. Her cholesterol balance test implies borderline hyperabsorption, but for production overall is not bad. But where she carries the most risk, of course, is in this excessive particulate generation or apolipoprotein generation that comes from the atherogenic apolipoproteins. So what is the most powerful marker here that you would focus yourself on? You will focus yourself on the total amount of ApoB containing particles, right? You can think of it as the loaded gun. This is what spits out there in the circulation to really expose her blood vessels. And we are seeing some beginning of vascular endothelial dysfunction because of the elevation of lipoprotein LPPLA2 activity. And those two will be critical markers. And despite the fact that her liver production is actually normal, we do know that statin medications, even lower doses, potentially may decrease the ApoB particles as well as LDL1Ps, which carry the highest proportion of cardiovascular risk. So this is advanced lipid analytics, but you could see that now we have powerful measures of how this patient may not respond. I can tell you that she's not insulin resistant. You could see the fact that she's actually clearing pretty much almost all markers of insulin resistance. Also, in our centers, we use a specific digital diagnostic to help us understand what the cardiometabolic patterns actually are. And both of these patients are treated through a proprietary program using this digital diagnostic tool. So finally, we're going to case number 3, because I do want to show you one more case and also go over the panels that I'm using and leave some of the time for questions. I could see questions are coming up in the Q&A box, but I hadn't had a chance to look at them yet. But here's a patient number 3, and this is a patient, and they just all happen to be women. So I guess they fit the phenotype, although we have about 60% women and 40% men on our platform. This is a fairly young patient. She has labile blood pressure, and she's referred from her functional medicine primary care physician. Now, the issue with her is that she's 52 years old, and she is reporting these episodes of elevated blood pressure. She is symptomatic, and it's very concerning because you could see here she experiences headaches and double vision. She essentially has periods when it's going over into 160 millimeters of mercury over 111, which is a very scary thought. Not taking blood pressure medication regularly. Her primary care functional medicine physician has her on several supplements and also on testosterone cream. She's not getting estrogen or progesterone treatment, but she is known to be a hypothyroid. So she's also on Armour thyroid. And you could see some of the laboratories that came through upon referral that she has this perimenopausal pattern. Although her estradiol is still in a very good range, her FSH is actually climbing up. Her dyslipidemia is mild. This is actually an improvement. She was much higher than total cholesterol of 233 and LDL-C 141. Her ApoB is under 100, which is the first level where you want to be at. Her TSH probably could be optimized a little bit more. We don't have systemic insulin resistance if we use hemoglobin A1C as 5 as a marker of that. She's struggling with weight loss. She's not on any weight loss medications. She wishes to lose 40 pounds, go back to the weight that she had before she started with her hormonal alterations. But there's some concerning findings like lower extremity edema, for example, with these levels of blood pressure. One would think, does she begin to develop left ventricular hypertrophy? Although her recent echocardiogram and stress echo were negative for that. And she has no discernible coronary artery disease. Her coronary artery calcium score is 0. So what can we do for a patient like this? Boston actually has a wonderful new tool called Cardiovascular Map. And I was privileged to be a consultant for development of Cardiovascular Map. This is not her Cardiovascular Map because hers is currently pending. But you could see that Cardiovascular Map in many ways allows us to go and quickly get the most actionable markers that will prompt the intervention, both lifestyle and pharmacological intervention. And the way that I look at it is like a Disney World Animal Kingdom. You go onto Discovery Island and you're Pandora, and then you end up at Oasis. So what do I mean by that? Discovery Island is actually a combination of markers that allows you to understand a patient's atherogenic lipid phenotype. And Pandora are the things that you may be careful with discovering, but they make a huge impact, such as lipoprotein little a, and of course, vascular and systemic inflammation, as well as cholesterol balance and the particles themselves, because all of these modify vascular risk. So when you start at the discovery atherogenic lipid phenotype island, you will first look for the signs of this lipidemic triad: elevated ApoB, elevated triglycerides, small dense LDL cholesterol, low HDL. You will figure out which of those atherogenic lipid phenotypes a person may potentially fall into. And then you will hike to Pandora to look at the world of lipoprotein little a, deal with lipoprotein little a situation, definitely address inflammation, look at the cholesterol balance, stop at the particle to refine your risk assessment. And hopefully by the time you hit the oasis, you will have a good grasp on what should be personalized risk prediction, and actionable steps that your patient may need to take. So, in terms of polygenic risk, this particular patient, I also did a polygenic risk course. Again, you can get it from Boston Heart Lab. It's an absolutely a blockbuster type of a test. This is actually done with reference to UK Biobank. So it's a very diverse group of individuals, and they're pulling actually from various ethnicities into UK Biobank as a reference database. And what it's doing is it's summing up multiple genomic variants that are associated with polygenic risk for hypertension. So you could see in this particular patient that 247 or 151,000 genomic wide variants were analyzed. And this patient is at a high risk, polygenic risk of hypertension. So we definitely, given this, I think while lifestyle modification is always at the front and always the first and most essential step that a patient may need to take, this potentially will need to be treated pharmacologically because of how high of a burden she has in terms of her polygenic risk scores. Also, she has a family history of obesity, and her adult children are struggling with obesity, and she's unable to lose 40 pounds. And this is an opportunity for us to understand potentially this could be a patient who could be helped by newer medications, such as GLP-1 agonists, because the polygenic risk score for BMI, for high BMI over 30, is actually high. So these polygenic risk scores, when you order them, you can specify if you're ordering for a specific issue, for example, just high blood pressure, coronary artery disease, or you can order the entire panel. I typically order entire panel. So what I'm not showing you is all the additional outcomes of it. The scores for coronary artery disease, atrial fibrillation, Alzheimer's, dementia, breast cancer risk, because these scores were normal in her case. She only was in the highest risk strata for the BMI and the high blood pressure. So just keep that in mind. Now, she also had certain areas where we can make an impact with regard to her GI kit. This is another test that we use, which is a stool test, but it's very specific because, as you saw earlier in the presentation, it looks at the particular areas of relevance to cardiovascular and cardiometabolic conditions. So in her case, there was certain areas where she can improve. And you see the list of food on your left and some of the supplements on your right that you can discuss with a patient as part of that lifestyle strategy that we need to implement right now to regain control of her blood pressure and also to help her lose weight. So what are my panels? I do want to leave a little bit of time for questions, and we have about maybe 7 minutes or so to go through the panels. I think of them as if I were building something with Legos. I'm sure you know what Legos are. Maybe you played them as a kid. Maybe your kids are playing Legos right now. But here's a duck and a little flower, a little tree. And look at this. You can assemble 4 different ones. And they all have the same pieces or nearly the same pieces, but they all look differently. So this is a challenge, right? Assemble the panels and figure out which of your patients should use which panel. We want the testing to be cost effective, and we also want it to be actionable. So some of the panels that are used, I use the atherogenic lipid phenotype panel, which I built using existing Boston Heart components. Also a panel for something called statin overprescribing solution, which is a group program, cardiometabolic panel, and even the panels that I can use for patients with outside blood testing, which was our patient from case 2. You saw that she had extensive blood testing with us and from previous providers. And we really needed that specific proprietary testing from Boston Heart Diagnostics to allow us to identify what are the type of interventions we can potentially go over. So in terms of the panels here is that I do use LipoMap, cardiometabolic comprehensive, a lot of other markers that are falling into place for the atherogenic lipid phenotype that allow me to look at cardiometabolic implications, inflammatory implications, hormonal implications, and even immune system activation. And you could see that the panels you can potentially shrink. You don't necessarily need the whole huge heterogenic lipid phenotype panel. You could go just stay with cardiometabolic and be a little bit more focused, or even use the proprietary testing such as HDL map, cholesterol balance, or lipomap as an add-on to actually dive fairly deep into the situation. I do want to mention specifically the cardiovascular map. Cardiovascular map is a highly actionable test. It's not providing you with 300 biomarkers, but it's providing you with the biomarkers that will be the type of markers where you will specifically execute on lifestyle and pharmacological interventions. And the CV map right now, if it's out of pocket payment, is only $199, which is amazing. You could get all this information. And if you are suspecting some thyroid dysfunction in your patient, I usually check a TSH if they haven't had it checked. So for $217, you're going to have the best of both worlds. A little bit more of a basic assessment and then assessment, which is a little bit more involved, including assessment of dyslipidemic triad and inflammation, as well as the particles. So where can you find more information? So I do teach practitioners, and I have something called statin overprescribing solution, which is a practitioner focused course. You can certainly scan on this little QR code with your phone right now. Then you point later, and you will be taken to a page that allows you to sign up for the course and to see our curriculum. And we go pretty much in depth, not just in terms of cardiometabolic and lipid testing, but inflammation testing, metabolic testing, monogenic, polygenic testing, and cardiac imaging, including some of the newer technologies available right now for cardiac imaging and atherosclerosis evaluation. I also run something called Integrative Cardiology Practice Support. It's a community. You can join this community, the Holistic Heart Center's Holistic Heart University. You could see here that for professionals, we go through quite a gamut of all sorts of things. We have live office hours, we have case discussions, practice hot seats, all sorts of journal clubs and event schedule, and so on. And I'm going to stop here and grab a sip of water. I did not get a chance to go through the chat box, but if there's any burning questions, I'm going to switch into the Q&A because there are 15 questions here, and just see if I can consolidate them a little bit. So the first question, I actually do that question, and I think I may have answered it live. What are the most one or two comprehensive Boston heart diagnostic tests that are close to catch-all as we can order? When would you lean towards one versus the other? So hopefully you had seen from these case presentations how I'm leaning one way versus the other. I think if you're new at starting this, go with CVMAP. This is a great catch-all test at a great price point. And I believe also have some insurance coverage, although please reach out to your Boston Heart Diagnostics or group on this issue because I don't run an insurance-based practice, so I can't really tell you specifics about the insurance coverage. But it's a phenomenal test for you to start with. And then you can add, remember my Lego strategy, if you need additional pieces, and you'll be able to pull them in the mix. So we'll answer that live. Okay, some question here. Are the various Boston Heart Diagnostics cardiovascular testing findings from the biomarkers thought to be more accurate than those received from the few big conventional labs? The labs all go through rigorous verification and certification. And of course, they calibrate their testing and their equipment. So I don't think that one lab is necessarily more accurate than the other. I think that everything depends on context. I say that you need to understand what the testing context is and what each laboratory is giving you in terms of the information, how you're going to pull this information together. See more about methylation, uniqueness impacting various tests, runs beyond homocysteine. I can't actually, because I think this is something that you need to clarify with the lab itself. They do provide a reference in their test, which test may be impacted, for example, by taking biotin and whatnot. So this is lab specific, and you will find it in the description of the test on their website. Matt, hi Matt, nice to see you here. What was the regimen you used in case one to see these positive changes? As I mentioned before, I run a proprietary program called Fit New Genes. We're currently training practitioners in that program, and it involves cardiometabolic modification with digital diagnostic, as well as specific nutritional and supplement interventions, and of course, a comprehensive cardiovascular assessment. So that was the quick answer to that. Did aspirin therapy decrease her CRP? Good question. It might have. We don't know, but she obviously she was a participant in quite a few things, and I think that together helped to drive her CRP down. We aim to achieve metabolic flexibility in all of our patients, and I can tell you it's amazing to see how many patients think they're doing the right thing, but they're actually not metabolically flexible, especially when it comes to young women. A big issue that I'm seeing is under eating of carbs and actually under eating of calories, which is terrible. And that sort of sets them metabolically on the path. Lori treatment with the first patient, I believe I already answered that. A question, often homocysteine or homocysteine cases. It's a great question about methylation supporting foods. The highest level of homocysteine that I had seen in a patient that was not my patient was a patient that another physician was asking an opinion on. So I really couldn't really render any specific program to that patient, but their homocysteine level was 39. And this was a very sick patient. We can certainly go into discussion of nutrients as they relate to the favorable changes that you need to implement for your patients. And perhaps I think we are in some conversations as Rupa with regard to boot camp, so we can always make it part of the boot camp and dive deeper into this. How often you come across homocystinuria? I think we talked about that. Question based on lab results, if you use nattokinase or lumbokinase. So I don't use either nattokinase or lumbokinase. I'm a cardiologist who doesn't use these things. I use aspirin. The reason for it is that all the literature that I had seen so far is not been internationally reproduced. It's coming from one source, one country, and there really isn't a very strong knowledge base on this. I had reviewed several papers, and I found a lot of them very flawed in terms of methodology. Unless I see something more robust, I will not be using these agents. Data, however, is very strong, especially for lipoprotein little a elevations in patients with monogenic and polygenic inheritance and use of baby aspirin. And most patients tolerate it very well. What are my favorite supplements for vascular cardiac inflammation? Dr. Brent Gould, thank you for asking. I like to make my patients metabolically flexible. So usually my go-to bergamot, berberine, and alpha lipoic acid, but then the rest of it really depends on what is it that I'm seeing from them in terms of body composition and CIMT and genetics and blood work and just where they've been and where they're traveling. So that's a very quick answer to this. And of course, never forget your magnesium and your methyl factors and your vitamin D. If you go with those 5 or 6, that would be my go-to. Okay, regarding blood spot testing accuracy, specificity, sensitivity, debating on a blood spot versus phlebotomy. So I have found blood spot actually quite accurate, even when I run it on top of the laboratories that previously were obtained. But with regard to the testing accuracy, I think this is something that you need to ask the lab more specifically. I have not seen any accuracy issues. But obviously remember that a patient needs to collect appropriate specimen. If a patient didn't collect appropriate specimen, which could be challenging for some patients, you may potentially see numbers that don't make sense. So you just be aware of that. And so I think I answered this live. Dr. Schultz. Interesting question here from a recent point. How does coronary calcium study compare with dry blood cell marker monitoring when baseline is borderline high? I'm not sure baseline or borderline high. I'm assuming you're referring to the blood test. The coronary calcium and dry blood spot are two different things, right? They're like pieces of the puzzle. And I encourage you to explore statin over prescribing solution course because we have a whole module on cardiac imaging, including coronary artery calcium score, CT angiography, as well as clearly the new artificial intelligence enabled reading of CT angiograms. And just in case you're interested in this, there is a very interesting technology called CARIT that is coming out from Britain. It already has EU approval that actually images perivascular fat inflammation. So those are really big ones, but prognostically, in terms of what was coronary calcium versus dry blood spot or any other markers, the modification of vascular risk depends on the full picture. So if you want to go, for example, into MESA calculation and plug in the coronary calcium score, in addition to other clinical parameters, you will actually get a numerical estimate based on the patient age and gender. What is their near term, which is 10 years, risk of cardiovascular events? And so for people on tight budget, what we recommend minimum necessary testing to assess risk, definitely CV map, because this is the best price point that you can possibly get right now. And it's like Goldilocks, not too much, not too little, just right for most patients. All cardiovascular tests considered from what you currently understand of the markers you covered today, which ones can we not necessarily move with lifestyle modification? And can we actually move the numbers with natural strategies? Okay, so that's a fair question. So I think the more your atherogenic lipid phenotype falls into this dyslipidemic triad bucket, right? So you're seeing combined dyslipidemia, you're seeing high ApoB or higher ApoB, seeing high triglycerides, you're seeing small dense LDL cholesterol come up out of bounds, the more likely you are to succeed with lifestyle intervention. You will be successful with that to a degree with the ApoB, which is more powerful predictor than LDL cholesterol, and to a certain extent with LDL and VLDL particles. But at that point, and then you saw it in case one, once you remove that cardiometabolic influence, you will still potentially encounter the markers that didn't quite budge to goal. So you saw in the first patient, they improved, but that was a very minimal improvement. Her dyslipidemic cardiometabolic drivers resolved, but her genetic drivers are still there. And then when the patient in case number two, significant improvement, but the residual risk continues to be on a higher side because the ApoB particle number is just so high. And this is now the impact of her genetics. And this is where most likely I will encourage her to use at least a low dose statin drugs to actually shift that marker, right? But now she knows, and I know what is it that we need to be shifting and in what direction. So I mentioned already that I'm not sure about insurance coverage of the cost of testing. I know a lot of Boston tests are covered by insurance, but please ask your local rep to be sure. If you order tests, are we able to discuss results with a laboratory expert? If the treatment protocols are proprietary. So they do provide actually a great treatment recommendation for you. There is a booklet. It's called Lifestyle Plan. So each of your patients gets it. Just when you order it, remember to check it off so that you can actually receive this. And the question, I am available to see patients. I see patients in 9 states virtually. I see patients in person in New York area, New York City and Long Island area. And if you're not in my 9 states, you can be a peer referring physician and we can do that. Boston Heart is different than CardioIQ. CardioIQ is Quest and Boston Heart is Boston Heart. Do I think HDL over 85 is dysfunctional? Not necessarily. What if you look at the studies so far, the most recent articles actually have not shown a big impact of HDL efflux capacity. It's not as predictive as the HDLP and different types of HDL particles. And let's keep on moving here. What mechanism of action does D-ribose do for these patients? So it wasn't for all of these patients. It was for a specific patient based on her GI kit result. And I think this is to replenish some of her microbiome, which seems to be underrepresented or deficient. So it's not part of the heart failure protocol or mitochondrial energetics protocol. It was strictly microbiome. And actually, I wouldn't give it to her because with her being obese and this blood pressure being so labile and issues that she has hormonally, I certainly would move more toward making sure she's not insulin resistant and don't want any sugar on board exogenously. Yes, I use PCSK9 inhibitors if I have to. I actually prefer not to use them because they're not particularly cost effective and that their impact is limited to a specific group of patients, even though a lot of people jump on the bandwagon of using them. They're not the most useful drugs that we actually have. It is important. There are a couple of other questions. Yes, nutrient deficiencies are important to identify in general, and that sort of bridges us to the next question. We have Mediterranean diet is a great approach for most patients. I would say modified Mediterranean diet, which strives for low glycemic index and appropriate fasting or time restricted eating intervals. Notice appropriate with appropriate macronutrient combination is definitely key. There are patients who swear by carnivore, high fat keto diet. I can tell you that in clinical practice, it usually is not aligned with what the patient needs. Although I'm sure there are some patients who happen to be very well on it, but not in my practice. Very often I see the type of patients who have tried keto diet and now they're coming in with cholesterol over 300, and those are ApoE4 patients and so on. And I think we have about literally a few more minutes. Questions on genetic and epigenetic testing. So I use a company called GB Insight. It's GB as in George and boy. And it is one of the partners or currently a developing partnership from Boston Heart Diagnostics and GB Insight. And they recently had a webinar on this that you may wish to take a look at. And the question that follows that, genetic epigenetic testing. So we are not in the infancy stage. We are at the stage of clinical implementation, certainly for monogenic and polygenic risk scores. In terms of epigenetic testing, that's an entirely different discussion that I'm happy to have at some point. But the polygenic risk scores, and certainly whether they're pathway specific or population based, and I showed you examples of both, are beyond the infancy stage. They should be part of the clinical practice. And as I said before, I encourage you to explore our course because we do discuss it directly. Is Boston Heart offering a coupon to those on the call today? I'm not certain what is meant by that, but I would ask them if they're offering anything because I honestly don't know. And I think I'm going to stop in 2 minutes. Do you find 23andMe similar company reports raw data useful? No, they're useless for our purposes. Move on to other companies that allow you actually to provide medical grade actionable genetic information as opposed to just interesting curiosities. And I think we are good here. I believe I gone through most of the questions. And if I didn't, please reach out. I'll put my email here so that you'll know how to reach out. And then, of course, if you are in the practice support community, I will see you there. So you can go ahead and reach out. And I'm going to thank Rupa for having me and thank all of you. I'm impressed with the amount of people who join us in the middle of the afternoon. Exciting, but thank you very much for having me.
Hi, everyone. We hope you enjoyed this class. If you're a practitioner, make sure you go sign up at rupahealth.com. And if you like this video, don't forget to like and subscribe.